The authors have no relevant conflicts to declare. In this video, we present a treatment algorithm for managing intrameniscal cysts with open repair and fibrin clot augmentation. Preoperative MRI is routinely ordered to define the pathology. T2-weighted MRI sequences demonstrate intermediate signal within the meniscus parenchyma, as seen on this coronal slice. The sagittal view shows an enlarged posterior horn with intermediate signal that does not communicate with the articular surface and therefore does not meet radiological reporting criteria for a meniscal tear. Diagnostic arthroscopy is performed to exclude the presence of any intra-articular extension which would otherwise be managed according to the tear characteristics. Using a blunt probe, the meniscus can be assessed. Here, the meniscus can be seen to be rolled using the arthroscopic probe. The posterior horn demonstrates an enlarged convex border. The surface anatomy is marked to help orientate the incision. The joint line is traced, as well as the femoral condyle and anterior and posterior tibial borders. The posterior medial aspect of the joint is palpated. A 3 to 4 cm incision is made 1/3 above and 2/3 below the joint line. Soft tissue dissection is then carried out down to the retinacular layer. The retinaculum is then opened to expose the joint capsule. Care should be taken to protect the branches of the saphenous nerve, which can often be seen crossing the surgical field. Recapping the surgical layers, the retinaculum is exposed and incised obliquely. This layer can then be reflected inferiorly to expose the joint capsule. An L-shaped capsulotomy is performed to expose the peripheral meniscus. A scalpel blade is used to incise the meniscus transversely. A diamond tip rasp or curette is used to debride the degenerate tissue and stimulate healing. An autologous fibrin clot is prepared and then placed into the defect. Absorbable 2O PDS sutures are used to capture the superior and inferior leaflets of the meniscus and secure the clot in position. This step is repeated as needed to complete the repair. The capsulotomy and retinacular layers are repaired and the wound closed in layers.